Hello and welcome to Individualizing Management Plans for Type 2 Diabetes through Shared Decision Making and Office Hours Activity. My name is Lucia Novak, and I am the president of Diabesity LLC and the co-executive director of Capital Health and Metabolic Center of the Capital Diabetes and Endocrine Associates located in Maryland. Thank you to Peerview for providing the session and to Lily for providing the educational grant for this activity. Throughout the presentation, please watch for additional follow-up polling, and you can submit your questions using the chat feature. I will be answering them live in the chat during the first 30 minutes of the program and live on your screen for the office hours portion in the second 30 minutes. You can view and download today's slides as well as the helpful practice aids on the Peerview website. So before we move on, please take a moment to answer a question on your current approach to shared decision making. So today's webcast was designed to fill gaps exposed by other recent continuing education activities on type 2 diabetes and weight management. And here's what we noticed about primary care clinicians' responses to some questions about initiating discussions for both type 2 and weight and using the shared decision-making process. While many of you answered questions correctly, we did see that some of you were unsure of your answers, maybe due to lack of confidence or just not enough information or knowledge. But we also identified some that were answered incorrectly. For instance, narrowly focused on clinical endpoints rather than the broader clinical context. For instance, you're looking at their hemoglobin A1C, and maybe you weren't realizing that a medication could also be really good to reduce the risk for a heart event or for heart failure, something along those lines. That you really weren't using shared decision making all that much, and you're more likely to rely on personal experience rather than the clinical evidence or the science backed evidence that we use when we're practicing. So therefore, our goals for today, we're going to initiate discussions about weight management and treatment intensification with people with type 2 diabetes who also have overweight or obesity. And hopefully, we will be able to equip you with strategies that will utilize shared decision making and help you to develop those individualized care plans. Starting the conversation. So what we're looking at here on this slide are the ADA, or the American Diabetes Association guidelines, that show that shared decision making is actually an important part, an essential part of developing that person-centered care plan that everyone speaks of when we're trying to help manage type 2 diabetes and actually any chronic disease that our patients might have. And as you can see, it goes around in a circle, and it starts with addressing the patient's key characteristics, thinking about specific factors that might impact your decision as to what treatment the patient may need, but then also using the information you gather from the patient to create a dialogue, a shared decision process where you can both then agree on a plan, implement that plan, provide ongoing support for the patient as they try to continue to implement, and then determining at a follow-up appointment somewhere down the line whether or not the plan that you both agreed on is working and do we need to make any tweaks. So for today's talk, we're going to be focusing on the blue box that identifies utilizing the shared decision making to create that management plan. And when we look at the details that are involved with shared decision making, one of those things is making sure our patients have access to diabetes education and support. So DSMES stands for Diabetes Self-Management Education and Support. And so making sure our patients have access to certified diabetes care and education specialists, certified classes for diabetes education, and registered dietitians who can provide medical nutrition therapy support for our patients. that's just the baseline of what they would need so that they can better participate in the shared decision making with you. And then, of course, we're going to involve not just the patient themselves, but if they bring someone with them to that appointment, a support person, we want to include them as well. And I encourage my patients that if they live with someone or have someone that they rely on to assist them with their activities of daily living or medication taking, that they include that person, invite them to join us, because you could always use an extra set of eyes and ears at an appointment. And then, of course, we're going to explore what the patient understands, what their preferences are, and how we communicate to the patient. Also, want to make sure that we don't call them a diabetic or that they are obese. We want to use patient-centered or patient-focused language. So it would be you have diabetes or you also have the disease of obesity. It kind of gives the person their autonomy and it doesn't assign them a diagnosis as to who they are. And that really does matter. And then talking at the last bullet about motivational interviewing. And I think when people hear motivational interviewing, the eyes just kind of roll back, because we understand that while it is important to do motivational interviewing to involve the patient in the decision process, it's probably a skill that many of us don't use very often. We may not be comfortable with, and we're probably thinking, oh my goodness, I don't have the time. So hopefully I can share with you how I practice, and maybe it can help make it seem less intimidating for you and the patients as well. We know that shared decision making works. So it would not be included as a recommendation in the American Diabetes Association guidelines if there wasn't some research behind it to show that it actually does work. And so this is just one of many studies that looked at shared decision making in a population that have type 2 diabetes. And what we found is that about 38% of the patients that were polled in this particular study perceived that they had some degree of shared decision making with their clinicians. And less shared decision making was associated with the person being older, being male gender, or uninsured. And so, again, we want to try to bring these numbers up because we have seen that when shared decision making is at a higher level or a higher perceived level, there is an increased satisfaction with care. And when patients are satisfied with their care and they feel that they are being included and adequately addressed, them and their needs, they tend to be more open with us. And as a result, we get further with them when we're trying to accomplish certain goals. Shared decision making was not necessarily associated with medication adherence, but it could be just the way that that was measured. I have seen other studies where we have seen a drop in hemoglobin A1C, as well as improvement in depression scores, as well as diabetes distress with patients who feel that they have an open dialogue with their healthcare provider and that they feel that their questions and their concerns were included in the development of the plan. So while we know it's important, it's obviously included in the guidelines. We have data that supports that it is very effective. What's probably missing for most of us clinicians is that there really isn't much guidance on how to involve patients in the shared decision-making process. And so the Mayo Clinic probably has done most of the research that is involved with shared decision making. And they have come up with three approaches. One is to share that information. So, again, and that's a two-way street, the patient sharing the information about themselves once they understand what we are working toward. You know, does what we are presenting to them work in their life? And we are also sharing the information about what the disease process is. what we are trying to help them accomplish, and what therapies are going to be needed to accomplish those goals. The second approach would be patient choice. And so I I proceed with caution here because yes, their patients always have a choice, and no choice is also an option if they choose not to do anything. What our responsibility is to make sure that they are making an informed choice. So if you think of shared decision making almost like informed consent, then you will have a better understanding of what the shared decision making process is. They need to know what the results are of their actions as well as inaction, and what are the realistic options that are available to them. And then they can make a choice. Of course, the third approach is having a conversation. And to me, that would include both sharing the information as well as understanding what the patient's choices are and why their choices may be that way. Before we move on, please take a moment to answer a poll on patient attitudes towards shared decision making. So let's first introduce a case, and this is a woman that is 57 years old, and her name is Anna. She is newly diagnosed with type 2 diabetes, and you saw her for the first time about a month ago. At her diagnosis, her A1C was 8.9%. And at her initial visit, you referred her to diabetes education as well as a registered dietitian to help her with her lifestyle changes that were needed to better manage her diabetes as well as improve her overall health. She did indeed attend the classes and has met individually with a registered dietitian for her medical nutrition therapy. And she has found that using the plate method has been a simple as well as effective way to help her with making appropriate portions and also working on decreasing her intake of ultra processed foods. She is now walking twice weekly for at least 20 minutes, and she wasn't doing that at that initial visit. So now we need to get Anna talking about how she feels that she is doing and what we think needs to be done better. And I will tell you that a patient's ability to want to participate in the shared decision making process is really going to depend not on just how much knowledge they have, but how much perceived power or capacity that they can bring to the appointment. Is their opinion taken seriously? Do they value their own opinion, or are they deferring primarily to what you're telling them to do? So, our goal is to help our patients feel empowered in that encounter so that they can be involved. But there are things that get in the way. And some of the things come from the healthcare provider side as well as from the patient side. So, what I have found, especially in diseases where lifestyle modifications are a significant part of the therapeutic plan, whether that be type 2 diabetes or overweight or obesity management, we have some inherent biases. We're human. We're going to bring those biases to every appointment we have with our patients. It's important that we understand what our biases are because they will translate. And oftentimes, if we're not aware of them, they will not be in relation to what words we are saying, because our body language and other things will convey a different message to the patient. So we want to make sure that we understand what our limitations are and that we address them. You can't get rid of your biases, but you can address your biases, and you can tone the language and change some things about yourself that will actually bring the patient into that empowerment phase and participate in the shared decision making. And as I mentioned, the patient also brings some baggage with them. And oftentimes, what I have come to appreciate, it's not just whether or not they have an income that can afford the medications or afford the appointments, although that is rather significant. But our patients aren't just people with diabetes. They are patients with a full life. And there are so many other things that can get in the way. And if you look at just the cost of receiving care for diabetes, 20% of it is spent on just getting access to us. That doesn't talk about the medications and so on. But they have families and they work and they may be in school, and there's all these competing priorities that sometimes overwhelm the patient and will limit their ability to successfully implement a plan we may have discussed, or from participating in the appointment in general. They may be ashamed, they may be embarrassed, or they just might feel like they just don't know how to even begin to talk to us about what's going on in their life. So there are some ways to kind of bring that information to them. And so this slide is showing you from the bottom up. So we would start by engaging the patient. And that again is not just by the words we say, it's also by our nonverbal communication. And that would include making sure that the seating in your office is accommodating for people who do have overweight or obesity, that they feel comfortable coming into your office and sitting down. And then using your body language where you're making eye contact and you're leaning forward and listening. And the other piece of that is also if you ask them a question, and hopefully an open-ended one that they are going to need to think and give you the information that you're looking for, that you pause long enough, because sometimes this might be the first time someone has actually asked them about what's going on in their life in a clinical appointment office. And so don't be in a rush to fill in the dead space of no talking. Allow the patient to process your question and then give them time to answer. I like to use the acronym WAIT, or W for why, A for am, I for I, and T for talking. Why am I talking? Let the patient fill in the void with the question that you have posed them. The next step would then be focusing. I like to ask my patients when they come into the office with me, was there anything specific that they really needed to address today before they leave my office? I may have a whole different plan in mind, but I have come to really appreciate that when patients feel that whatever need they had got addressed, even if I did not get to some of the things I felt were important, they leave my office feeling very satisfied, very heard, very listened to, and they're more likely to come back for their next follow-up appointment and will continue to be engaged. So again, trying to develop an agenda with the patient. They may have some things they want to address, and you can say, okay, and I have some things that I also want to make sure we cover today. So let's get to it. And then, of course, comes evoking, making sure that you are helping the patient to bring forth whatever information you need. And that could be by finding something positive that is going on in their life. So, they haven't taken their medication, they haven't done walking, their diet hasn't been the best because it's the holiday. And I say to them, but you're here today. And that is huge, because they could have chosen not to keep the appointment, as often happens when patients feel that they have not kept their end of the bargain. So I'm always looking for something positive to kind of reassure them that I am on their side with them. And I recognize the difficulty of trying to manage more than one chronic disease. Diabetes seldom comes by itself. There's usually the buy one, get three free, hypertension, dyslipidemia, weight, and then the complications of the weight. They may have bad knees, a bad back, they have sleep apnea, so on and so forth. And again, this is just a piece of who they are. There is so much more to their lives. So trying to get them to talk to us is going to be really important. And then the last thing is, once we've gotten them talking and we've identified some things that are important to them, we have relayed the things that are important to us as far as their management, then we can come together and determine a plan that we both feel comfortable with and that the patient feels able to put into place. So the 4 skills are going to be Open-ended questions, which I mentioned, those affirmations, again, trying to find something positive about what the patient has succeeded with since their last appointment, even if it is just coming in today when they felt that everything was just lost since the last appointment. And then, of course, the reflective listening, validating what they have to say. Oh my goodness, I can only imagine how hard this is for you. You have so many medications that you have to pay for, and you're on a limited income. So let's see if we can't figure out how to better address this. Again, you're listening to them. I see that this upsets you, and you know what? I understand why you're upset. Those are huge, validating the patient, what they're feeling. And then summarizing what they have said. This is what I'm understanding is the issue. These are your concerns. Please let me know if I've misheard you. And then also inviting them to summarize what they have understood from you to have said so that you can clarify if there was anything. When we talk about obesity management in specific, because it is such a high stigma associated chronic disease, we are actually encouraged, and Medicare wants to see this documented in the chart, that you are using the 5 A's when talking about sensitive subjects, and that includes when you're discussing somebody's weight. And so we would be asking for permission. That's something that seems strange. We don't ask permission to discuss their blood pressure or their cholesterol. They're in our office. We assume they are here for our help. But when it comes to a stigmatizing type of disorder, we do want to ask their permission because maybe they don't want to talk about it. And what we need to do is at least open the door. We're asking their permission, letting them know that they have the ability to participate in this conversation or not. If they're wanting to talk about it that day, then we let them have at it, correct? Like, we go ahead, tell me what's going on and what you've done that worked and what hasn't worked and what can we try to do better. But if they say, you know what, today's not the day, I just am not ready to talk about my weight. And you can then say, okay, I just want you to know when you're ready, I'm here and we can talk about some things that we can do together and leave it at that. And I have found that patients will come back and be ready to have those conversations. We are also overwhelmed as healthcare clinicians on different goals that we need to help achieve with our patients. So, what exactly are we looking at? Are we looking at improving their diabetes? Are we looking at reducing their weight? Is it their blood pressure? Is it their cholesterol? So, a lot of competing, again, priorities, but oftentimes they're so often interwoven that if we can address one, we typically do a really good job with addressing the others. And this slide is showing you an example of therapy that we can use that can do that. So certain medications, and you're seeing here a pattern of the GLP-1s and the SGLT2 inhibitors that will help reduce that atherosclerotic cardiovascular disease risk, help improve glucose as well, and not necessarily increase weight for our patients, hopefully helping them to lose weight. So, it's important that we give this information to the patient that there's a potential that using one or perhaps maybe two drugs, we'd be able to hit many things. What I like about this particular slide is it helps set the stage for when we're talking about weight loss with our patients. People with type 2 diabetes do not lose as much weight as those without diabetes on the same exact treatments that we use for obesity management. And what this slide is showing you is the average weight loss that you can expect when taking these medications. So patients, they seem to think that if I start this drug, I'm going to lose 50 pounds. And that's not necessarily going to be true. Everyone responds to these differently, but this gives us an idea of about how much weight we can at least expect a patient to lose, and then what else we might need to do to help the patients accomplish those goals. And it could be combining agents, it could be referring them for a bariatric procedure, all of those things. So before we move on, please take a moment to answer a poll on goal setting in type 2 diabetes. So when I have a patient that is not comfortable with intensifying treatment or wanting to use a medication, especially when it comes to type 2 diabetes, I will bring up the ominous octet. And the name is going to be changing to Noxious 9. And I think Dr. Stan Schwartz actually has an egregious 11. We keep finding reasons, pathological reasons for hyperglycemia. And the reason I bring this slide up with my patients is to show them there is not a mouth and there is not a foot on this particular slide. And it's not that the lifestyle as well as what they're eating and what they're drinking are not important. I'm trying to focus this less on the shame and blame that often is tied to nutrition and physical activity and more on the disease process. And just based on this slide alone, there are 8 things outside of how much exercise a person does and what a person eats that contribute to that hyperglycemia. And that is going to set the stage to help me to help them understand why a medication is needed. And patients really do want to know what to expect from a medication, not only the side effects, but I often get, am I going to need to take this for the rest of my life? And I tell my patients, my goal is that you live a very full life with very few complications and on the lowest dose of medication that you would need. So it's going to depend on many things, on what type of medicine and how long they would need it. And again, we as clinicians need to be comfortable with the medications that are available and how to prescribe them and what side effects to counsel the patient on to expect. What I love about this slide is that just as if a patient were on blood pressure medicine and they decided, oh, your blood pressure is at goal, let's stop the blood pressure medication. You don't seem to need it anymore. What we would see is their blood pressure would rise and their hypertension would no longer be adequately addressed. And that is true for just about any disease, to include type 2 diabetes and obesity. So when patients ask, how long do I need to be taking something? I tell them, as long as you have the disorder or the disease, I do not have a cure. We need to do our best with maintaining stability so that you have good health with minimal complications. So now that we've covered the groundwork, let's revisit Anna, our patient that we discussed and I introduced you to at the beginning. And this activity does include some helpful practice aids. And again, you're going to be able to download them from the PeerView website. But let me show you how I would use them to navigate patient-centered discussions to reflect Anna's needs and goals. So today, Anna is in for her first month follow-up with me since her initial diagnosis of type 2 diabetes. She's already been to see the dietitian and she's attended classes. Today, she's expressing concern that while her blood sugars have gotten better, they remain above the targets discussed of less than 120 and less than 180 after she eats. She said she's running anywhere from 120 to 130 before she eats, but it's really her after meals that are concerning her. They're going up as high as 210. And she's also upset that instead of losing weight, she is gaining weight. And she reinforces that she was really hoping to avoid medications. This was something that she mentioned in our initial appointment a month ago, which is why I said, okay, let's get you in to see a dietitian. Let's get you into some classes, and why I scheduled her appointment with me for a month later so that I could quickly intervene and make sure that she was doing okay. So these are her concerns, and now we need to address them. So this slide here is facilitating discussions with your patients about intensifying therapy for type 2 diabetes and weight. So I didn't mention Anna's weight, but most 42% of the adults in the United States have a BMI that's high enough to put them in the obesity category. So it would not be surprising that there was some issue with weight. So while I may not have mentioned it, let's say that she does have a BMI of about 32. So it's not just enough to address her blood sugars, but we also have to think of that comorbidity. On top of that, she's gained more weight. So I'm going to reassure her that the weight gain that she experienced is a natural phenomenon that we see when blood sugars actually get better. And so our goal is that with ongoing exercise that she has implemented and the significant changes to her diet, that will eventually even itself out as her glucoses improve, and hopefully she will start to lose some weight. But I am concerned, as is she, about her post-meal elevations. So we'll talk a little bit more about what it is that she's eating, see if there's anything else that we can tweak. But this is where I am going to talk about type 2 diabetes as a disease process, not just focusing on the lifestyle management. And so, again, this is where I will bring up that ominous octet with her. And I will show her that outside of what she eats and the exercise she does or does not do, there are 8 pathological functions inside her body that are contributing to the hyperglycemia. And I can also going to show her some of the medications that we use for managing diabetes. And yes, I will include insulin in this discussion because I never want insulin to be made to feel as a threat or as a punishment. But we'll talk about what the options are, what the benefits are, and go on from there. And so hopefully by the end of that appointment, she's willing to do something in addition to taking a medication to help reduce her risk, to help get that A1C down, and help her live her best life. So before we move on, please take a moment to answer a question on your practice strategies. All right. So, in conclusion, and to summarize, that when you're starting that shared decision making process with your patient, please remember that there are some important things to consider. Not just the patient's point of view, but if they do have a support person in their life that does help them with activities of daily living or management of their disease process, whether it be helping them with meds, have them bring that person in because they can provide some additional insight. And keep in mind that we have tools available, not just for the patient, but also for us as clinicians to kind of help guide us through this process and to really strengthen our skills. And then making sure that we implement strategies that we feel comfortable with to get our patients participating in those shared decision making and understanding that those preferences and those limitations that the patient may have to be part of our consideration when we are developing that plan. We know there are many benefits to shared decision making, and probably the most important of all is the increased trust that the patient will have in us as their healthcare clinician, but also the trust that we now have in them that they are going to be forthright and, honest with what's going on in their life, regardless of what's going on in their life and how it may actually make them feel, that we are on their side throughout the process. So this concludes the formal part of my presentation for today. If you missed the first 2 office hours activities on prioritizing weight management and overcoming therapeutic inertia, please search for office hours on the PeerView website to locate these activities. Now it's your turn. Please stay tuned and I will answer as many of your questions and challenging cases as possible. Hi, everyone. I hope that you enjoyed the video and you were asking some really good questions in the chat, as well as sharing some concerns or frustrations that you have as well. And I'm really hoping that you will be willing. I've kind of encouraged you to bring your questions to the group because I'm sure you're not the only one that feels that shared decision making just doesn't seem to be working. People don't stay engaged. You send them to the dietitian changes the recommendation that you made. I need to hear like what your frustrations have been, what your experiences have been, so that maybe we can kind of talk through it. I'm almost doing shared decision making with you right now, if you think about it. So one of the questions is, please let me know how effective tirzepatide is compared to just GLP-1 meds in controlling glucose and getting patients A1C to less than 7, and regarding weight loss, number of pounds or kilograms versus GLP-1 meds. So we kind of use all of the GLP-1s as one big title. But what you're mentioning is that tirzepatide is the only dual agent. So it's a GIP-GLP, meaning it's a GIP and a GLP-1. And we have others that are coming out soon that are also combination, maybe with different peptides, combination of 3 different peptides. And so what we know when we look at medications, and you can think of this in any form of a combined drug, when we give patients complementary synergistic medications, they tend to do better with less side effect, and they also seem to have a greater impact on achieving an outcome. And so that's no different with the tirzepatide, is what we have found, that the combination of GIP and GLP-1 receptor agonist has allowed us to use a little less of the GLP-1, and the GIP actually has an ability to reduce the nausea and some of those side effects that patients typically experience. And because it's a dual agent, they tend to be even more effective. And so we do see greater A1C reduction. We see more weight reduction with these drugs. It's not to say that the GLP-1s are not effective or impactful. I have some patients that actually tolerate and do better on a GLP-1 monotherapy than they do with the combo. So it's really finding what works for your patient. And, you know, when you're having the conversation with the patient about what the drugs are that are out there, these are some of the things you want to bring up. And we just got even more data about the fascinating accomplishments that we can get with GLP-1 and now even the combo. The FLOW trial showed that the GLP-1, at least semaglutide, has impacted renal function. So if patients cannot tolerate an SGLT2 inhibitor and they're on a GLP-1, rest assured that you are addressing renal function with those drugs in a positive way. We are also seeing tirzepatide being used now with the indication, hopefully soon, if not already, to treat sleep apnea. This is happening even before the weight loss is experienced. And we're now seeing with the STEP HEP-PEF trial, which is the obesity trial using semaglutide, looking at heart failure, preserved ejection fraction in people with obesity, and seeing that it actually helps with heart failure in that population. So these are the things that I think help when you're trying to put patients on medications. So thank you for asking that. Another question is, would this medication be safe for persons with fluctuating blood sugar, including overnight lows that lead to binge eating at night? So I'm assuming this medication is the GLP-1 or a non-insulin agent. Especially, yes, we could use those drugs, mainly because when you use them, we can probably pull off the drugs for hypoglycemia. So I had someone who mentioned that he doesn't really believe that patients follow through when it comes to exercise or lifestyle changes. And as a result, I think we start to get a bit jaded as clinicians when we're kind of like, oh my God, not another person with diabetes who just needs to, you know, lose some weight, maybe be a little bit more active, and they're just not going to do it. That's actually a bias that we are now forming And if we bring that attitude with us to that patient encounter, the patients will feel it. You may not think that you are relaying or portraying in some way that you don't really think that they're going to be able to do it. I kind of think about it in terms of, I have a relative who's got Alzheimer's, and when they have Alzheimer's, they ask the same question over and over and over again. You just feel like you hit play, and that's what your afternoon or an hour with them would feel like. And, the worst that you can do is get upset or, oh, you asked this question 10 times and, be frustrated, because then it causes them to be upset and anxious and frustrated. So I treat each patient as if they are an oyster with a pearl, right? That their moment is now. And it takes some work and some energy to bring that to each encounter. But, don't let previous encounters with the same patient or even with other patients color what this patient might be able to do. I think there are more reasons for patients with diabetes to not come in to see me than there are reasons for them, right? There's a lot of shame and blame with diseases that have anything to do with lifestyle management. And it's not just diabetes, it's also obesity. There's just this, if I eat and do everything I'm supposed to do, then I promise I'll lose the weight, my A1C will come down. When they are saying those things, that's the shame and blame talking. They don't really understand that this is a chronic disease, and that in addition to their physical activity and healthier eating habits, they also are going to require medication to help manage this disease so that they can live their best life. And so that's one of the things I bring up to a patient, especially one that I feel like we've kind of hit this wall and we don't seem to be making any progress. I give them homework because this is not something that they often can answer right in the office with me. But I ask them, what do they envision is their best life? And what about their health, whether it be their diabetes, whether it be obesity, heart failure, whatever it is, what about your health is getting in the way of doing the things you need to do for yourself? And what is getting in the way of the things you want to do for yourself? Two very different questions. And I will give them that homework and say, I want you to think about this and come back in and let's talk about what you envision you want your life to be and how then I can help you get there. You're not going to fix everything, and that's really not our job. I think that most of us as clinicians, we go into the practice because we want to help people. And sometimes we feel that some folks are just beyond help. But I have yet to find a person who comes to see me who has come to see me because they are hoping that they will go blind, or they are hoping that they will end up on dialysis. Nobody wants to be sick. No one wants to feel ill. No one wants to be coming in and wasting time off of work to come and see someone for their health. They would much rather take that time off and maybe go on vacation, right? So, I understand that this is challenging. There are many competing priorities in people's lives. Unfortunately, diseases like diabetes and obesity, they're silent. By the time someone feels pain or has a problem that they can say, oh, that's because of my diabetes, it's often that they've been struggling for a really long time. So it's easy for these diseases to kind of get pushed to the back burner while they address other needs. And oftentimes those other needs might be their children, their parents, another family member, maybe it's work. I'm always trying to find out what is getting in the way. I never try to have the patient feel that they are ultimately responsible for not doing something. Diabetes is buy one, get three free. So how many drugs are patients taking just because they were diagnosed with diabetes? They find themselves also now on a blood pressure medicine that they did not need before that diagnosis. Maybe now they're on a cholesterol medicine that they weren't prescribed before. And the list goes on and on and on. And it can be overwhelming. And so I think we need to sometimes just take a step back and just empathize what could possibly be happening in their lives and let them talk. I try not to say too much at the beginning of the appointment. I need to hear from them what they need from me before they leave out that door. Because as you can tell, once I get started talking, it's hard for me to stop. So, I'm looking to see if there are any other questions. I'm hoping that you guys are all still on and engaged. But if you have like a scenario that you want to share where you actually did try shared decision making and it kind of went sideways, or something else happened that you just feel like, I just don't have time to do this, I'd love to hear it. And hopefully we can, as a group, maybe think about ways to make those encounters more impactful. And I encourage you, little steps, not real big ones. So someone has asked a question or has posed a statement. Marge says, I always use motivational interviewing. What is the goal? Like, how do you feel? Certain size. So is it how you feel that your goal? Do you want to be a certain size? Is there a certain amount of weight that you're wanting to hang your hat on? Or is this certain A1C? So the patient's going to tell you, I want to weigh 130 pounds. I may not have weighed 130 pounds since I was a junior in high school, but that's my goal. And then Marge says, and then you have a realistic conversation about a reasonable timeline, as well as a reasonable goal to achieve this. And you need at least a year long term with shorter terms in between. I agree with you. So we know that it's not going to take overnight. It's not going to take a couple of months to get a person to where they probably need to be. So we could say, okay, your overall goal is to get your A1C down from 10 to less than 7%. But I know that if I try to do that in a month, I'm probably going to make their neuropathy worse. I'm probably going to make their retinopathy worse. They're not going to feel so good. It's just not going to be a good experience for anyone involved. So we can say, okay, but a safe reduction is if we can get you, 0.5% down every month that I see you. And, that's the beauty of continuous glucose monitoring when it's available for the patients, to be able to use that real-time data, using your certified diabetes care and education specialist to help you. And if you really feel that you're struggling making a connection with a patient, I will often say, you know what, I want you to see my colleague. And there are several of us in the practice. We call ourselves the diabetes divas. And we will often brainstorm with each other. And I will, I might say, hey, I'm sending this patient to you. I think they need a different perspective. And sometimes that helps. So, trying to always think through. Jay Schmidt says that I had a 60-year-old patient, a male with diabetes and a BMI of 34. We discussed cutting out non-water beverages such as soda, iced tea, lemonade, sports drinks, juices. So non-caloric beverages, excellent. Limiting sugars and creamers in coffee and cutting out desserts and snacks. We also talked about carbs and limiting bread like pizza, rice, pasta, potatoes. We talked about forming good dietary habits and integrating one step at a time. He seems motivated, and we plan to follow up every 1 to 2 months for weight checks and to integrate more positive changes into his dietary lifestyle. That is awesome. I will tell you, I don't have very many patients that are going to be able to do all of what you did in that one appointment as far as setting goals. Some patients are ultra motivated, and you can set multiple goals like that. And sometimes they will already come to you having said, look, I cut out this, I'm doing this, what else can I do? But I will switch this a little bit. And if the same patient was drinking non-caloric beverages, putting sugar and creamers in their coffee, eating desserts and snacks, eating a lot of rice, bread, and pasta. We've got to break that down. And so I'm not going to say, hey, how about if you give up your caloric beverages and drink water? This is where I'm going to say, this is what's going on. These are the things that we need to work on. What do you think is going to be the easiest for you to achieve? So maybe they're going to say, okay, I'm going to try to cut out bread. Okay, that's great. We've identified bread, but maybe this person eats bread at each meal every day of the week. So now I need to know that. Well, how often do you have bread? Well, I really only have bread with my dinner. And then I have like a muffin at breakfast. Okay. So let's pick one of those meals. I'm starting to work on a SMART goal with them. Okay. I need to be as specific as possible. So he's identified, okay, it's the bread that he wants to work on. So we're going to he is going to cut out the bread with dinner every evening for 1 week. That is what we call a SMART goal. It's measurable. It's meaningful to the patient. He identified what he wanted to work on, and we gave him a timeline to do it, to see how it feels, how he's doing. I didn't give him like 3 months and say, see ya. So these are some ways that we can use that motivational interviewing and working with the patient so that they actually tell us what their goal is going to be. I could have easily said, I don't want you drinking any caloric beverages. And, you know, if that's the only vice that that person has, he's going to be like, no. I've had patients that actually come in to see me sometimes and say, you're not taking away my vanilla wafers. You can do anything else you want to do to my diet, but you're not taking away my vanilla wafers. I'm like, okay, you can have your vanilla wafers, but let's talk about some other things that we can adjust in the meantime. So again, trying to get the patient to own the problem and to own, even more importantly, the solution. And you are their cheerleader. That's what I do most of the time in most of my appointments, especially in my diabetes and obesity appointments. I'm their cheerleader. I am going to guarantee that I will find something positive about that appointment, even if everything else went sideways. They didn't get their labs done. They didn't bring in their meter. They haven't filled the prescription for their medication. They haven't started the CGM, blah, blah. I mean, the list goes on. But for some reason, they came into the appointment. So that's what I meant when I said sometimes people have more reasons to not come in than to come in. And I will find something positive. And the first positive I'm going to find is, hey, thank you for coming in. Now let's talk about what got in the way and work on at least one of those things that went sideways. Any other questions or anything? CWD says, we try to make shared decision-making if there are clear, reasonable, and attainable goals, such as someone who is usually sedentary, incorporating walking 2 to 3 times a week. It is reasonable to try lifestyle changes. However, I also usually offer patients a medication to lower blood sugar more quickly while working on being consistent with lifestyle changes. This is usually well received and ultimately see benefit in patients reaching goals and being part of decision making. Excellent. That is excellent, because you're including the patient. You're not just saying, here's a drug, because I don't think you're gonna succeed with your lifestyle changes, which is the perception that some patients will feel. You're saying, look, let's get these blood sugars into a safer range so that as you're incorporating these new habits and making them permanent, then we can reassess about whether or not we can pull the medication off. So, and you bring up an interesting point about, exercise. I had one patient that figured out on their own that they needed to do 30 minutes of exercise, but could not do it all in one fall swoop. So they started doing walking in place before they ate each of their meals for 5 minutes, and walking in place after they finished eating their meal for 5 minutes. So they got 30 minutes in, and they strategically placed the exercise before and after each meal they were able to come off 2 of their medications. So, if we give patients the opportunity to figure things out and we can kind of guide them, they actually do well. Isaac says, not typically successful without a multidisciplinary approach. I 100% agree with you. We don't have the ability to do all of this on our own in our appointments. He also says that the best outcomes and success come with deliberate focus on patients' long-term goals, incorporating therapeutic lifestyle change and medication. My approach would be to use motivational interviewing to help patients define their actual goals, yes, then present options to achieve that goal, yes, and the most likely outcome would be that patient would choose to initiate a GLP-1 to augment or maximize the benefits of their important sustained therapeutic lifestyle changes. Absolutely. That is exactly what this is all about. Helping our patients to understand. And when I mentioned in the video that if we think about shared decision making along the lines of an informed consent, when patients get a procedure, they are told what the risks are if they don't have the procedure, what the risks are if they do have the procedure, how long they're going to have the surgery, what the recovery might look like. They understand everything, and then they have to sign that they understood everything. And that's really what shared decision making is. It's helping our patients be a part of the discussion and understanding the decision or the choices that they're making. Thomas says that weight loss improves as the dose increases, but what is the maximum dosage and why was that dose chosen? Do side effects at that level become more common or more serious? So I think we're talking about the GLP-1. So yes, we do see a dose related weight loss associated with the GLPs, GIPs, and we also see an A1C reduction association as well. The doses were figured out during preliminary studies where they're trying to figure out the most effective dose that's going to cause the least amount of side effects. So those are their safety studies. So that's how they are determined on the doses. And then the side effects don't necessarily get worse as we increase the dose, typically because patients are starting to adapt. But that's, again, discussing with your patient, how are they feeling, what problems they are having, if they are skipping doses or not feeling well, what's going on, and counseling them about how to mitigate those side effects on their own. Maybe they're eating a lot of fried foods, or maybe they are still believing that they need to eat 3 meals a day instead of much smaller, more frequent meals during the day. So you can have this discussion with just about any aspect of their care. So when a patient comes in and their A1C is 8, and the last time you saw them, it was 6.5. My first question is, what the heck? It's not going to be like, what the heck happened? Why is your A1C 8%? What are you doing? Right? It's going to be, so since the last time I saw you, have there been any changes? Have you been sick? Were you in the hospital? Any changes to people in the family? Get them talking and feeling safe, because they don't even need to tell you what happened. If they say, my daughter has been in the hospital, I already know why their A1C went up. Okay. Their priority was no longer themselves. It's now their child, and maybe they're not sleeping. Maybe they're not eating properly. They may not be exercising. They're probably not even going to work, and stress and anxiety can do a lot. Adelia, when is the correct place to add after failing metformin 1,000 twice a day? So patients don't fail their medicines. I like to kind of twist it. The medications fail them. It's not working. Okay. So if you have them on maximum dose of metformin and their A1C isn't moving, then yes, you're going to add additional medication, and you're going to choose that medication based on the most current ADA guidelines, which actually tell you to look at that whole person. Do they have cardiovascular disease, heart failure, kidney disease? do they have comorbid overweight or obesity? Are they at risk for injury if they should have a hypoglycemic event? And so then you would determine what's going to be the next best step if metformin doesn't seem to be enough. Jim Greco says, what about the reported muscle loss with Ozempic? Loss of muscle decreases the ability to burn calories. Are we seeing muscle ligament damage? That's a great question. And actually, in the ADA's 2025 standards of care, they actually have several times listed as recommendations that patients who have either received bariatric procedures or are on the pharmacotherapies that can give as much weight loss as the surgical procedures, that we are inquiring about their eating habits, because malnutrition is very important. And it's not just Ozempic. If you're not eating enough calories, and I really don't want anyone, even if they're trying to lose weight, to be under 1,200 calories. To me, anything less than that is a very extreme diet. It's not sustainable, and we can see a lot of issues with health. And protein intake is going to be important. Well, when they're on Ozempic or Mounjaro or any of the other meds like that, they can go all day and not eat. They can go all day and not drink. So not only are they not getting 1,200 calories, some days they're not getting any calories. And so we do need to inquire about what they're eating, how often they're eating, and we need to give them some ideas about how they can get that nutrition in. And that's sometimes where the protein beverages can come in handy, because you don't feel like chewing and swallowing, but you can drink on something. Okay, and I think that was the last question. I appear to be out of time. I thank all of you for joining me this evening on a Wednesday evening. It's very cold here in Maryland. I don't know where the rest of you are, but wherever you are, stay safe, stay warm, and work on having those dialogues with your patients. It will be very meaningful for both you and them in the long run, I promise.